Hi, everyone, and welcome to the MedSLP Summit. We're going to get started in just a few minutes. But first, I'd like to introduce tonight's presentation sponsor, AmpCare. If you are watching from YouTube or the MedSLP Collective Facebook page and would like to receive ASHA CEUs, you can upgrade this week at medslpcollective.com/summit upgrade. If you are a member of the Medical SLP Collective and are on the live ASHA CEU track, please make sure you are logged into Zoom with your MedSLP Collective email address. The quiz for the live track summit participants will be available after tonight's presentation. The quiz for the recorded track summit participants will be available tomorrow morning. Emails will be sent with quiz links. Please check your spam folders for these notification emails. If you have any questions about ASHA CEUs and registration, please contact info@medslpcollective.com. Hi, everyone, and welcome to our third and final night of the MedSLP Summit. We are going to kick off the night with Carly Schiff, and she's going to talk to us about understanding voice and its many elements.
Hello, everybody. I hope everyone's having a good night, a good Wednesday. I'm going to go ahead and share my screen so we can get started. Okay, can we see this all right? Perfect, let me set it. Okay, so I'm gonna talk about, understanding voice and its many elements and how that fits into voice therapy. My disclosure statements, I am receiving some payment from the MedSLP Collective for this presentation, and then I am an employee at Penn Medicine's Becker ENT and Allergy, where I am a speech language pathologist. I'm going to cite my things at the end of this, but a lot of this is created from my clinical experience and going to speak a little bit about how that plays into the evidence-based info I'm going to give you tonight. Quick bit about me. So I'm the director of voice and swallowing at Penn Medicine's Becker ENT and Allergy, which is a large general ENT practice in South Jersey and into PA and Philly area. I'm a past musical theater performer turned SLP after experiencing many of my own voice disorders growing up. I trained and worked at the Blaine Block Institute for Voice Analysis and Rehabilitation, where I was also a patient when I was younger. And then I went on to Columbia's Voice and Swallowing Institute in New York City, where I was lucky enough to work with many Broadway performers and work with a lot of singers in general. And now I work much closer to home and at Becker ENT. So I don't know if you guys can see my thing in the way. I'm going to move that. There we go. So how voice is made. And this is like a very simple version, but you may remember this from your graduate studies. We saw this logo of, we've got your three subsystems of voicing. You've got your breathing or your respiration, your phonation, which is source, your vocal folds, and then your resonance, which is everything above the level of your vocal fold. That's where your sound is filtered or resonated to help create the sound that we hear. And we're going to get into each of these elements more specifically. So we're going to start with respiration, our power source, okay? And how this relates to voicing. So respiration is your power behind vocalization. Vocalizing should occur on the exhale. So this is a really important thing to remember when you are doing voice therapy with somebody. Inhaling is definitely important, but how voice is made is by air coming up from your lungs, from your diaphragm, coming up through the vocal folds, past them, setting them into motion, and then allowing the sound to come out. Coordination of this exhalation and the onset of phonation or voicing is vital for efficient voice usage. And we're going to go over that some more with how this relates to voice therapy techniques. Working on respiration alone in the absence of any voice will never improve a voice disorder. And I'm putting a caveat, unless a person has known respiratory issues, but in which case you're really not working on voice, you're targeting respiration alone. Now, you have to have good and strong respiration in order to have good voicing because it is our power source. So yes, if somebody has COPD, if somebody just came from being hospitalized and they're very weak overall, those things can absolutely affect voicing for sure. But if you're just working on breathing exercises and not how breathing and the voicing coordinate together, then you're solely working on respiration. You're not really working on voice because respiration is one element of how voice is made. Having enough air before speech is important, but using the air that you took in is the most important. And again, we'll get to this when I get into the therapy techniques. What I mean by that is someone can take a big breath in, fill up their lungs, raise their shoulders, get the biggest breath in they could possibly take. And if that breath is held, they're not using any of that air, and then voicing is not going to be efficient or have good vocal quality. So let's talk about how this element of respiration fits into common voice therapy exercises. So I know that voice therapy is not one of the things that's really taught in grad school. And so sometimes when you have someone who's, going to get a voice patient and they don't do voice generally, you have these thoughts in your head like, okay, I know my resonant voice therapy, I know this thing called semi-occluded vocal tract postures, and maybe I know vocal function exercises, and I know LSVT. And those protocols are very rigid, and that's good. They're evidence-based. We want to follow a protocol, but understanding what elements those exercises are targeting will really help you be able to fix it if it's breaking down for a patient, if you're not hearing what you think you should or what you learned in the training. So respiration. Resonant voice therapy is one of the most common voice therapy exercises that is used by any voice specialized SLP or even a general SLP. The main focus of resonant voice therapy, if you're not familiar with it, is to try to feel the vibration of your voice and your sound on the lips and the face. And we use frontal consonants such as and because if you do that correctly, you're going to feel that vibration. In order to do this appropriately, though, patients must allow exhalation to occur at the onset of phonation. So if you are humming, which is the first step to resonant voice, but a patient is holding their breath, so they take a breath in, but they almost like bear down, like they're doing, going to the bathroom or doing a glottal closure for swallowing, and they end up holding back that air. You may hear a resonant sound because we're using those frontal consonants, but if you try that at home, you're not going to feel that vibration here. So if your first thing is asking the patient, where do you feel that? Or do you feel that up here? And they say here, check their respiration. Are they allowing exhalation to occur? Mary made me mad. So I'm feeling that sound on the exhale and using those frontal consonants to help me feel that frontal resonance. Flow phonation, moving forward, is the main focus of this is to allow airflow and typically using physical feedback such as like a tissue to see the air flowing. So doing like a So this one is a little bit more obvious in that you have to have the exhalation because if not, your tissue is not going to move. So I don't have that air flowing. But something important to recognize with flow phonation is that we don't want to have too much respiration or exhalation. We don't have too much air coming through, but we want to have a consistent exhalatory flow of air. Because if we get too much air, we may see the tissue move, but the voice sounds crazy. And that's because you're trying to drive too much air through and it's almost blowing the vocal cords apart. You can think about if you've ever gone to a door and you go to open it and it's much lighter than you expected and you sort of open it and fly backwards, you're using too much force. And the same thing with voice. You want to have good exhalation, but you can't have too much. And this plays into part a lot with how our vocal cords work and close. And we're going to get into that in a moment when we get to phonation, but just understanding that respiration and exhalation and flow of your air has a lot to do with how the vocal folds are resisting that as well. So if you've got a vocal fold paralysis or paresis, it can't resist that air. Or if you've got vocal cord atrophy and the vocal cords can't close really well, it can't resist that air. And so figuring out based on what you know of the diagnosis, do I need a little bit less airflow, though still consistent, because there's this big glottal gap from atrophy or vocal fold paralysis? Or are there big nodules and the vocal cords are super heavy? So now I need a little bit more exhalation because I need a little bit more drive. Like now I'm lifting the heavier object or opening the heavier door, and I need a little bit more. Straw and water, and I just have examples of all of this so that you guys can see it. So straw and water, this is just a semi-occluded vocal tract posture where we bubble into the water on an O sound like this. Straw and water is not a voice exercise. It is a semi-occluded vocal tract posture in which we can do voice exercises, meaning you could do stretches, glides up, glides down. You can use it before resonant voice therapy to try to help get the air flowing. You can do vocal function exercises on the straw and water. But just for your knowledge as an aside, if someone says, what voice therapy exercises are you doing? You say, oh, I'm doing straw and water. That in and of itself is not really an exercise or a therapy protocol, it's just a technique. Nonetheless, seeing bubbles in the water is a sign that exhalation is occurring. So this is a super awesome one to use as good visual feedback for patients. So if you're working on this and a patient is doing and you don't see the bubbles, it sounds strange. You need a little bit more exhalation, okay? Doesn't necessarily mean you need a bigger breath in, but you need more air coming out. So often I'll have patients start by just exhaling. Most people can just blow bubbles into water. And then you can add your voice on that exhale. Straw phonation is the same idea. We're just not using the water. So with straw phonation, you have your straw in your mouth. And if you put your hand at the other end, you should feel air flowing out. So that exhalatory airflow is coming, and that means the voice is able to move efficiently and not be restricted by the air being held right here. And then finally, lip trills, also known as the semi-occluded vocal tract posture. When you're doing a lip trill and the lips are trilling, that's a sign that exhalation is occurring. So you can do it without voice, and then all you're doing is turning on your voice. If the lips stop trilling, or it's really hard for them to trill, it's typically a sign that airflow is not occurring. So moving on to phonation and how it relates to voice. So phonation is the source, the actual source of voicing. So it's our vocal folds vibrating to create sound. To have efficient and clear voice from the phonatory level, meaning just the vocal folds, they must vibrate in symmetry, close completely or very close to completely, and vibrate flexibly. So there are many things that can make this not occur, including vocal pathology or inefficient respiration or inefficient exhalation during voicing. But these things must occur. So if your vocal folds are vibrating asymmetrically, you may hear a rough and raspy sound, or there may be more vocal breaks. If they don't close completely, you may hear a breathier sound because air is leaking through, or a strained sound because someone's trying to get them closed, even though they can't. And if they don't vibrate flexibly, often we're going to hear a lot of roughness in the voice. I see. Can you guys hear? Someone wrote that they can't hear audio. You guys can hear me, right? I'm going to keep going, assuming other people can hear me, or someone would have shouted at me thus far. Oh, we got chats. Yes. Okay, great. Cool. All right. So why can't I move? There we go. So speaking about phonation and how it fits into some common voice therapy exercises, we're going to go back to straw and water, or straw phonation glides. And so, like I talked about with respiration, straw and water or straw phonation, that is a technique, a semi-occluded vocal tract posture. But now I'm going to talk about gliding them. So doing like this. Or so the focus on gliding, pitch glides like that, on whatever technique you use, lip trill, or even the focus is stretching the vocal folds up and contracting them to improve flexibility or pliability. Okay, how we get higher is by having the cords be able to elongate and maintain their vibration at the same time. And how we get low is by them contracting. There are other muscles that play into part, not just the vocal folds, like your cricothyroid muscle. We're not going to talk about all of that right now. We're just thinking of it from the vocal ligament musculature and the epithelium and the superficial lamina propria, the different layers of our vocal folds. So an inability to phonate up high while doing straw and water, if the bubbles are still going. So let's say a patient's like this. That typically means a lack of flexibility or pliability in the voice. I'm forcing mine to do that because I'm a weirdo and I'm able to kind of like hold my cords really tight while keeping my air flowing. But that's sort of mimicking like a lack of ability to be flexible. Now, it could be muscle tension because that's basically what I just did was I kind of splinted my cords really tight, even though my air was still flowing. But a lot of the times, especially if you know what diagnosis is, vocal fold nodules or a polyp or a cyst or a scar, those kinds of things, if you're hearing those breaks as they get higher, it really means a lack of flexibility. But you want to make sure that you still have that respiration like we just talked about. So these are different elements, but we want them all to fit together. So if you see that happen up high, but you also see, and the bubbles stop, then you think, okay, well, what can I fix first? I know that there should be bubbles. Like even if someone's vocal fold can't do that, they should be able to continue their exhalation. So work on that first. And then if there's no sound, we say, okay, their technique is great. But when they get up high, it's just not coming out. And so then we think, is this a pliability issue? So we need to work more on that. And I always tell my patients, it's fine. As long as the bubbles are going, I want you to keep trying to make sound because it's like you're trying to stretch, you're trying to get more flexible. The more you do it, the softer things will get. So you can do, even if that voice is squeaky, as long as you have that exhalation, you know that you're not getting this really tight, strained muscle pattern happening in the vocal folds and in the throat. And that goes for any of the semi-occluded vocal tract postures, any of those. So now let's move on to vocal function exercises. So the exercise set by Joe Stemple, the focus of sustained phonation here. So just a very brief overview, vocal function exercises has that initial one where you sustain a note for as long as you can, then you glide up, then you glide down, so you have the pliability and flexibility, and then you sustain on different musical notes again. So the focus of this sustained phonation here is working on your average glottal efficiency time, which means how efficiently do the vocal folds vibrate and hold back the exhalation that you've started that's occurring. So a very short time on these typically means a lack of vocal fold closure. Now, it can mean that someone has respiratory issues at baseline. If you know that, if you know the person has asthma, they've had lung cancer, they have COPD, you know that their respiration is decreased at their baseline, that's fine. Then their ability to sustain something is their ability to sustain something. So if they can hold out just with like a sustained S, this is where our SC ratio came from. If you can just sustain if they can do that for 15 seconds, but on vocal function exercises, they can only hold it out for about 3 or 4 seconds. That means that air is leaking too quickly through the vocal folds. And that means a lack of vocal fold closure. Now, that could be due to nodules. That could be due to polyps, creating that hourglass closure. It could be due to a paralysis or paresis, making the cords not be able to close, or vocal fold atrophy. Or it could just be due to inefficient muscle patterning. So your muscle tension patients who aren't getting their cords closed. But you can know in your head that, okay, they have that lack of cord closure. So this may be something that over time just needs to improve, as long as all of our other techniques and your other blanking on the word, your other technique within the exercise is appropriate. So your exhalation, and then we'll get to your resonance. And then resonant voice therapy and flow phonation, like we talked about with the exhalation, the focus here is not actually very heavy on the folds themselves in terms of their flexibility and their closure and their symmetry of vibration, but more on the other two subsystems. So we're working on, again, that exhalation and feeling that resonance. However, if the folds themselves cannot vibrate very well or cannot close, then resonant voice therapy and flow phonation will be very tough. And the reason I point this out is that a lot of times I see, your general SLP who has a new voice patient just jumping right into resonant voice therapy. And don't get me wrong, I use resonant voice therapy with probably almost every single patient that I see. It is an incredible voice therapy tool, but it is not our only voice therapy tool. And it is not often the one that you can do right off the bat, because sometimes you have an actual pathology or an actual injury here, and it's going to be very hard to have good resonant voice or good flow phonation if you've got no flexibility or no pliability or very bad closure. So sometimes working on more of those glides or the semi-occluded vocal tract postures and a sustained phonation, sometimes that initially can help make this and this a little bit more possible in your functional exercises. Make sure I'm okay on time. Yes, okay, great. So last is our resonance. So resonance is how the sound is filtered once it's created by the vocal folds. It's really the last step in the vocalization process. So resonance is where we feel voice, okay? Voice is abstract, obviously, but I always tell my patients, you can imagine your voice is like little dots that you can visualize, and resonance is where those dots live. So if you have a very back-focused resonance or vocal fry, your little sound is stuck in here. And if you have that nice frontal resonance, then your little sound is like up here and kind of coming out to your listener, and that's what you want. We want to use our articulators to create a frontal resonance because that's the most efficient way to speak. Having a frontal resonance really means that sound is not being restricted or constricted by any part of our filter or our pharynx or our resonating cavity. So it means that the air that you've brought up, the vocal fold sound that you've created, it's actually able to be filtered all the way up and out to the listener, okay? So having using M's and N's, those are just nice articulators that allow us to feel that frontal resonance if we're doing it correctly. Doesn't mean that we can't have that on other sounds, we just won't feel it quite as well. Everything above your vocal folds is part of our resonating cavity or filter, not just the lips or the nose. So your pharynx, your base of tongue, your velum, your teeth, all of their placements can change our resonance. And this is going a little bit deeper than we actually need to know for the average patient, but having your velum up, right? Now we have a hyponasal resonance. That's not really how we talk, but sometimes for patients that are really nasally, or sometimes when I have patients that kind of like talk this kind of tight voice, we can talk about the velum a little bit. So just understanding those different elements of resonance is really important. So how it fits into our common voice therapy exercises. So resonant voice therapy, obviously, in the name, we're using the N's and N's, like I mentioned, to feel the vibration. Having stronger articulation can help a patient just feel this more. And so I tell my patients a lot, you don't want to over-articulate because we don't want to sound weird, but we do want to really feel our teeth, our mouth using this. If someone cannot feel this frontal resonance on an M and an N, like I mentioned before, look at the other subsystems, because if this and this is working correctly on an M, that's your resonance. So if they're not feeling it, then we need to check elsewhere, because that should automatically do it if these and these are in line with each other. One thing that I want to share quickly with resonance, and this isn't exactly what my presentation is on tonight, but I feel like I have to anyway. Having frontal resonance does not mean you have to have a higher pitch, okay? Changing your pitch is this. Having frontal resonance is where the sound is filtering out. So if somebody's talking back focus like this, telling them to speak in a higher pitch, that's not a frontal resonance. I do no longer sound like I have vocal fry because I'm straining to get my cords up, and talking up here is also not frontal resonance. Getting that sound, the air to flow, the sound that you've made to filter straight out of your mouth, that's frontal resonance. So just keep that in mind. With vocal function exercises, so our exercise set is done on these very frontal sounds. The exercise number 1 is on a sustained, and then the rest of the exercises are done on our buzzy. Now you can use any semi-occluded vocal tract posture if those aren't working, but those are the traditional vocal function exercises. And feeling the buzz that we talk about, that means that the sound is making it to the frontal space and isn't restricted. So again, our resonance is more of like a feedback as opposed to the focus. So if you have, ooh, and that patient has none of that buzz, where's the breakdown? Where are we constricting? And you got to look lower than where that very, very frontal resonance is. Is it a pharyngeal tension? Is it a base of tongue tension? Is it a false vocal fold tension? Is it that air is not flowing? What's happening with that? And same with strong one straw phonation. Again, the straw phonation, that buzz that you feel here, that's just feedback for frontal resonance. And then we have our airflow feedback or our bubble airflow feedback. So troubleshooting voice therapy protocols, I kind of talked about this intermittently, but when teaching any voice therapy protocol, you must keep in mind the 3 subsystems. For your brain, start at respiration. And by respiration, I don't mean inhalation, I mean exhalation, and then work your way to resonance. But remember, they kind of all work together, and figuring out the weak link in the team is vital. And what I mean by that, if somebody is really tight up here and they're not articulating, you're going to automatically feel more tension here. And I kind of hold my breath naturally. So they are a loop of a subsystem, but respiration is really what starts that drive to get the vocal folds moving to create the sound that we filter out. So start here and work your way up. Okay, so that is my presentation. So does anybody have any questions? I'll open my chat so I can see them. Or am I going to get them out loud?
So I can, I see one already.
Cool.
Do you find that patients can do VFE early on as a first approach in therapy, or do you train good breath support and try to facilitate good voicing mechanics first? I hear a lot of people will start there, and I haven't been very successful, lots of hyperfunction.
So yes, I start vocal function exercises with so many of my patients, so many. It's honestly, in my mind, almost always my first go-to tool, unless I have just a 100% primary muscle tension dysphonia, which means the patient has, no or bad voice due to muscle tension alone, and there's literally no underlying pathology of any type. But yeah, vocal function exercises does work on good respiration. So when the reason that people don't have success is when you spend 2 or 3 sessions just working on diaphragmatic breathing or exhalation with no sound, you're not working on voice at all. And so it's really hard to then carry it over. Vocal function exercises, like I mentioned, if you're doing that correctly, you're having really good exhalation. Oftentimes with my tricky patients, I will go ahead and do vocal function exercises on straw and water, because then you kind of have the best of both worlds. You know that they're exhaling if there's bubbles. If they don't have bubbles, you have to tell them something's wrong. But if you have consistent bubbles, respiration and exhalation are flowing. And then there may still not be perfect technique. You still have to work on other things, but you know that that's what's happening. In terms of your question of like efficient voicing, there are some patients who definitely do better understanding how this plays a role into like their daily speaking, but that's not always doable right at the beginning. And so I make a point with my patients to, number one, say, this may not change the sound of your voice and speaking, and that's okay. This is like our exercising, and then we're going to do our functional work, which is more our speaking. They do that in physical therapy a lot. You don't get to go in and do squats right away. You have to work on these isolated exercises with your knees or your hips. But I may show them myself how this sort of can carry over with resonant voice therapy, or flow phonation, even if they can't do it yet, just so that there's that little bit of buy-in, and they're not saying like, why am I making sound into water? This is never going to help my voice.
I think we have time for one more. Do you have, do you teach any voice courses or recommend any courses that you feel are essential?
I don't actually teach any voice courses, but I do have stuff on the collective. I have actually many videos of me demonstrating voice exercises. And I also did a webinar on paralysis and paresis and like went really in depth into how different exercises work for that. And I'm also always on the Facebook page answering questions, and I'm like totally willing to make videos of whatever therapy questions that you have. In terms of voice courses, so we have a lot of awesome ones on the collective. There's a lot of awesome, MedBridge courses with like vocal function exercises or Forte, but truly, and I'm not paid by them at all, my most favorite course that I've ever taken is Estel Voice. And the reason being is that it's very singer based. You do not need to be singer at all. They talk about vocalization in basically kind of how I do, but they break it into like 1,000 more pieces, and how each little element, from your jaw positioning to your velum, to your false vocal folds, your true vocal folds, your onsets, how those things create voice. And it has changed my way of thinking about voice therapy so much. It makes every little element that my patients have when I'm like, okay, why is this typical voice therapy exercise not working for this patient? I'm able to break it down. So if you're able to take that course, I think it will help you understand any other course that you ever take for voice.
All right. Thank you so much.
Yeah, thank you.
Are a few questions in the chat if you want to pop in.
I will do that right now, and I will stop sharing my screen.
Thank you so much.
Thank you.
All right. Next up, we have Katie Threlkeld, and she is going to talk to us about adult oral rehab.
All right, guys, let me get everything pulled up here. Carly, does that look okay?
Mm-hmm.
All right, great. So hello, everyone. I'm really excited to be here today to speak to the summit. We'll go ahead and get started. So my disclosure statement is I'll receive a payment from the collective for this presentation. I don't have any relevant non-financial disclosures to share. Everything that I'm talking about today has come from what I've found as a practicing clinician, what has worked for me in my clinical experience, as well as working with some really great audiologists who've taught me a lot about adult oral rehab, and then any resources that I've cited, and those will be on the handouts as well. So a little bit about me. I've been a speech pathologist for about 7 years. I started out wanting to do like pediatric language, and I've totally gone a totally different route, and I've really enjoyed kind of the journey. And one of those routes that I've gone is working with the cochlear implant team at the University of Missouri Health System. I've gotten to see individuals as young as 6 months old getting hearing aids, doing oral rehab with them, all the way up to a 92-year-old receiving a cochlear implant and successfully completing his program with me from an oral rehab standpoint. So it's been really fun. I've got to kind of see the whole lifespan in terms of AR. Today, I want to present specifically on kind of just an introduction to adult AR, since I've been doing some mentorship with the collective since about probably the spring. We've had some great questions on there, and hopefully I'll address some of those questions in this presentation and just give you guys a little bit more information and tools for when a patient who needs AR gets on your caseload. So what exactly is AR? Oops, I don't know what just happened to my share, but let's try that again. Presenter view. Okay, so there's some definitions. There's some good information on the practice portal on ASHA. So specifically, there are a couple different definitions that I want to go through here. So Montano said it is a patient-centered approach to assessment and management of hearing loss. And so that's not just individuals who receive a cochlear implant. That can be any individual who's had a progressive loss to a mild, a moderate, a severe hearing loss that's just received a cochlear implant, or excuse me, just received a hearing aid and needs some information and some treatment and compensatory strategies on how they can be successful in their everyday environment while they're coping with and learning to live with this hearing loss, and how to use that hearing aid to the best of their ability. So it's a person-centered approach to assessment and management of hearing loss that encourages the creation of a therapeutic environment conducive to a shared decision process, which is necessary to explore and reduce the impact of hearing loss on communication, as well as activities and participation. So again, we're thinking about how this impacts an individual across the different environments they're in, whether they're at church, at the grocery store, they're going out to eat with a spouse or a partner. We want to know how they can be successful in those environments from an auditory comprehension standpoint. Boothroyd defined AR as the reduction of hearing loss induced deficits of function, activity, participation, and quality of life through sensory management, instruction, perceptual training, and counseling. So again, I'm just kind of introducing AR today, giving you guys some information on what it is, what the evidence has shown in the past, what my clinical experience has been, and the kind of where this field is moving forward. So before we dive in, we got to kind of throw it back. back to maybe undergrad when you're in your first class learning about what an audiogram is. So this is a really great resource. Got permission from the Central Institute of the Deaf to share this. It's a little pediatric, but I really like it because I just use this with my adults as well. So they can really understand what their hearing loss means. Because if you tell them they have a high frequency, moderate to profound hearing loss, they're not really going to know what that means. But if you point out to them that they're having a hard time hearing sounds such as a bird chirp or sounds such as a really loud airplane, right? That helps them really visualize and understand what their hearing loss means and what they're really missing in their day-to-day environment. So if we're looking at the audiogram, and remember, this is a graph that shows the softest sounds a person can hear at different pitches and frequencies. So across from the top, from left to right, we have frequencies. So we have those low bassy sounds up to high squeaky sounds. Excuse me, that was on the left, and then or on the top. And then from the side, from top to bottom, you have volume. So we have those very soft sounds toward the top, and then we progressively move to louder sounds, such as like airplane or an jet engine. Those are lower down at the bottom. When we think about hearing loss, we think about the threshold. When you see, if you're reading an audiogram, that threshold is going to be the softest sound a person can hear. With an adult, 20 dB and above is normal, and with a child, 15 dB and above is normal. So, and just a little bit more kind of background information and just reminders. I'm sure we all learned this in undergrad and in grad school, but people get confused. And I think it's really important to, again, not only to be able to understand it as clinicians, but also to be able to explain this to our patients, to their family members that are coming with them to an appointment. What is a hearing aid? What does a hearing aid do for them? And then what is a cochlear implant? What does a cochlear implant do for them? People really confuse that, and they confuse how and why one of these systems would benefit them from the other. So what's the difference, right? Just in basic terms, we know that a hearing aid amplifies sound. That's all it's doing, all right? A cochlear implant is going to directly stimulate that auditory nerve. So hearing aids amplify sounds in a really sophisticated way by digitally interpreting information and then sending it through the ear canal, middle ear, inner ear, and on up to the primary auditory cortex. I find, and I know research has shown, really disappointing statistics in terms of how well or unwell hearing aids are programmed. So if you have a patient that just got a hearing aid or has had a hearing aid and they, complain they never wear it or it doesn't help, tell them to go get a second opinion. Tell them to follow up with their audiologist. They could have had a change in their hearing loss. It could be a situation where they need to go in and they need to have a follow-up. I have a grandpa who has several friends that it really disappoints me when they tell me they have hearing aids and they aren't using them, because I know how much it would benefit them from a quality of life standpoint to be able to participate in conversation with their peers, but they haven't. And I really encourage people to help them learn to advocate in these appointments. This is really helping me in this situation, in this environment, but maybe not here. So again, when we think about a hearing aid, there's going to come a time when a hearing loss is so severe, hearing aids can no longer bypass the areas of non-functioning hair cells. Therefore, no matter what, and no matter how sophisticated that hearing aid is, it can't get a clear signal to the brain. And as a result, the person with hearing loss like this is going to have really poor speech understanding. And that's when we would want to have them be seen by a cochlear implant team to determine if they're a candidate for a cochlear implant. So a CI, like I said, it's going to directly stimulate the auditory nerve. In a way, it is kind of bypassing those non-functioning hair cells to provide an electrical signal that can be passed on to the auditory system and to the brain. The goal of the cochlear implant is to really kind of step in and pick up the slack so that that hearing nerve can have a better signal to deliver to the brain than what it currently has with those damaged or non-functioning hair cells. Remember, if there's a damage at the level of the hearing nerve itself, And with most profound losses, there often is, the cochlear implant cannot bypass that damage, right? It will affect how that signal arrives to the brain. So we do, on the cochlear implant team I work with, we do a lot of counseling and education before they even get that cochlear implant. We have to remind them that a CI is not a quick fix. It's not going to be a guaranteed solution. There's a wide variety of outcomes for an individual who receives a CI. And so they really have to know that going into it and be really comfortable with the fact that this is not, put the CI on and have a magic solution. That's just not how it's just not how it's going to work. There's many factors that go into cochlear implant outcomes and outcomes for individuals who use a hearing aid, and aural rehab is one of those factors, right? The principles of what I discussed today, they can be utilized with individuals who are using both hearing aids and cochlear implants, but a lot of what I'll discuss today will be related to adult cochlear implant recipients. So again, there's a lot of factors that go into that initial AR assessment. There's a lot of factors that are going to impact their performance right at that AR assessment. So again, are they a cochlear implant recipient or do they just get hearing aids? We're going to also look at their age. We really want to get a great and really thorough background and information on the duration of their hearing loss and the type of hearing loss, because that will impact their performance. If they're an individual that just received a cochlear implant, I always want to know, were they wearing a hearing aid? And if they were, how long have they been wearing the hearing aid? Research has shown that if an individual receives a cochlear implant but hasn't worn a hearing aid for a long time, that auditory nerve has not been stimulated and can really impact their performance. So I work with really great audiologists who really encourage hearing aid use up until the point of that cochlear implant surgery and cochlear implant activation. So we're really keeping that auditory nerve stimulated. We want to know, again, like I said, type of hearing loss. In my experience, patients with noise-induced sensory neural hearing loss typically perform worse because of that level of damage to their auditory system. It's really unfortunate. I'm really thankful that my dad, who works around a lot of equipment, protects his hearing now, but he definitely has a level of damage back, in the 50s, 60s, 70s when we didn't know how important it was to protect our auditory system. And those are definitely the patients I see that struggle the most in terms of their outcomes after receiving a CI. We want to look at individuals, whether they have prelingual or postlingual hearing loss. So postlingual hearing loss, those are individuals who have developed hearing loss as an adult and have a short to a medium duration of deafness, while adults who are prelingually deafened are those who have early onset hearing loss. These are adults with very long periods of absence of stimulation to that implanted ear. So I have had individuals who are from the deaf D community who are fully immersed in the deaf community and use ASL that have received a cochlear implant. I had one patient who was in her late 30s and she had some children and she was really worried about the safety for her children to be able to hear when someone knocked on the door or if a fire alarm went off. And so that's why she pursued a cochlear implant, so she could have safety awareness in terms of environmental sounds. So you really do see a wide range of individuals who pursue CIs. And it's also important to know that the candidacy for cochlear implants is growing. Technology is changing. So we're seeing more and more people going this route. And so it's important to know that we have to look at all of these different elements as part of that AR process. From a cognitive standpoint, we want to know, are there any concerns noted by the referring ENT or audiologist? And a cognitive screen may be indicated. I definitely have done both cognitive communication goals and AR goals for some of my patients. So we're definitely looking at the patient as a whole and not just from an AR standpoint. We want to know what kind of support they have. I definitely want to know who's living in the home. Is the patient going to have someone who's going to be there with them to work on the home exercise program that I'm providing, and who can help them learn how to hear with this new equipment in their home environment? So who's going to be with them, and how often are they going to be with them? I also want to know any cultural considerations that may be important to the patient. And that can vary from patient to patient. So making sure I'm asking questions to get as much information as possible to take that into to consideration for my assessment. As part of the assessment, it's also really important to know what the patient's priorities are. Again, it's patient-centered. We want to establish goals with the patient and their care support in mind. So again, like I've said, asking them what they want from the CI, what do they miss from a quality of life standpoint. You know, I had one patient who was just so thrilled to, after he got his cochlear implant, he went to church that Sunday and he got out of his van and he was able to hear the church bells, and he hadn't heard the church bells in years. And so that was really exciting for him. And so then we worked on a lot of environmental sound identification and discrimination, so he could really be able to not only detect that the bells were ringing, but be able to tell that was a bell ringing versus a car honking, right? So really making it about the patient. Next, kind of as a part of that initial evaluation, we want to move into really AR specific assessments. So as a part of this, you want to get a self-report from what the patient has said, what have they noticed. Typically, in my experience, what happens is my patient comes in and they get the initial activation done with the audiologist, and then within 5 to 7 days, I see them for their AR assessment after they received a cochlear implant. So I'm going to want to know what they've noticed since that cochlear implant was activated. If they're a patient who's just received hearing aids, again, I'm going to want them to go home and have those hearing aids on at the grocery store, at the park, on the golf course, wherever it may be. I want to know what they're hearing, what's going well and what's not going well, so we can utilize that information as part of our assessment to plan goals. We want to also get information from the caregiver or partner or family member, friend, whoever that may be, that's going to be with the patient. From there, we want to move into their ability to detect, discriminate, identify, and comprehend sound and speech. So when we think about this, this is from the auditory skills hierarchy, and we want to look at each skill separately. So this work was done by Erber. He is who originally described this hierarchy of listening skills that consists of 4 sequential yet overlapping levels. This hierarchy of listening skills provides a framework for assisting clinicians in both assessment and establishing goals. So with detection, when we're thinking about detection, we want to know how well is a patient detecting and responding to the presence or the absence of sound, right? Not only are they hearing new sounds, the door close, the garage open, the TV turn on, but also what are they still not hearing? And again, this information is really helpful, not just for you in terms of setting goals. This information is also really helpful for the audiologist. So they can take that information as part of their mapping and programming and really utilize that in addition to what they're seeing in their audiology appointment. We're going to look at how well they're searching and localizing sound as part of that detection assessment. And we can also do what's called a conditioned response to sound. And that's something I won't go into too much now, but just know that that's another piece of detection, conditioned response, that can be really helpful for those who are not doing as well from a detection standpoint. Following detection, the hierarchy moves to discrimination, so the ability to perceive similarities and differences between 2 or more speech stimuli. So at this stage, the patient is not only detecting sounds, but they're starting to discriminate between sounds. Is this sound the same or is this sound different? Some of my patients only reach this level, and it can be really frustrating. But at the same time, we want to make sure they are maximizing their abilities at this level if this is as far as they get. From here, we want to move into identification. So this is the ability to identify and label a speech sound or a word. So with adults, it could be pictures or it could be words. We typically would have an open set, a closed set of maybe 4 to 6 words or items. I would say the word and I would have them identify what they heard. And after that, we're going to move into comprehension, right? So the ability to understand speech and spoken language. This is ultimately the goal for a lot of my patients, but we do know that they don't all reach that. But from here, we're looking at comprehension, both in really controlled, structured environments, so the therapy room, but we're also going to look at how well they comprehend speech and conversation in not such a structured environment. Try to make it really functional. A lot of times I'll turn on, a newscast on YouTube and have them practice listening in that environment to try to simulate what listening is like in a restaurant. So we're really thinking outside the box and trying to make it as functional as possible, because we know that patients aren't going out and listening in perfect, quiet, one-on-one scenarios. If you're wanting some sort of resources, unfortunately, there's not really like a true, AR assessment like the Boston aphasia exam, right? We don't have that in AR yet, but there's some really great resources out there. So there's 3 cochlear implant companies. We have Cochlear America, MedSLP, and Advanced Bionics. Cochlear America, all 3 of them have great resources, but Cochlear America specifically has some great resources for adult AR. Specifically, they have the Adult Cochlear Implant Home-Based Auditory Training Guide for clinicians, and they also have a screening tool within that. So that screening tool is able to be used to assess AR status post activation of a cochlear implant. It has components that look at phoneme recognition, sentence recognition, environmental sound recognition. There's some really great ways to guide a clinician, especially one that's new to AR, in terms of what they should be assessing and looking for. That will then in turn help them make goals for the patient. It's also, again, I said this earlier, so important to work as a team with your audiologist. I've thankfully had the experience of working with really great audiologists as well as a really great ENT, and we're very much a team. So if you're new to this or you're getting some referrals, be sure to reach out and communicate with the audiologist about what you're seeing, what the patient's doing well with and what they're struggling with, so they can use that information in terms of how they're programming and mapping that cochlear implant. Once we think about intervention, so again, we've talked about patient-centered care, right? So both based on what we've seen in the assessment, but also what their goals are, that's how we're gonna make our goals. So we wanna provide the patient with the ability to really have optimal hearing with their hearing aid or cochlear implant through personalized therapy that both identifies their daily communication demands. So are they an individual that still works? What does that look like for them? Or if there's someone that's retired, what are their hobbies? What does that listening environment look like? So identifying what their daily demands are from a communication standpoint. We want to assess their goals. So in addition to what we've done, we really want to think about their goals as well. And that includes both the patient, but as well as their family, friends, individuals that are in their life frequently. We want them to be a part of this as well. Therapy should identify and target areas of auditory weakness and address those areas of auditory weakness. A lot of this is going to be identifying compensatory strategies, educating a patient that, hey, you have a really hard time with maybe listening and noise, and you really like to go out to eat with your spouse. So let's think about in a restaurant, where would be the optimal place for you to sit? Where can we have you identify areas where you're going to really be successful when you're going out to eat with your partner, right? We want to teach and reinforce communication strategies, compensatory strategies, and techniques, and really provide them with appropriate resources. And we really want to personalize it to them as much as possible. Take their input and put that into your assessment in your plan of care. From an AR intervention standpoint, it really focuses on auditory training, which involves various levels of exercises that train the patient's brain to better recognize and understand speech with their hearing aid or cochlear implant. These exercises, in my experience, I typically, after someone has just received a cochlear implant or hearing aid, I'm scheduling them for maybe once a week for 8 to 12 weeks, depending on their needs. And I'm giving them specific things to work on every day when they're home, especially for those who have just received a cochlear implant, because they are typically seeing the audiologist every 1 to 2 weeks. So they're having changes in their program. And so we want to make sure we're providing them with resources that they can work on at home to meet the demands of their no cochlear implant program, because that could change from week to week. Tasks can focus on analytic training, like consonant identification or vowel ID or minimal pairs, looking at something like, and there's resources online. Again, Cochlear America has some great stuff. Making sure, like some patients, I've had an audiologist say, hey, they're really having a hard time with, middle vowels. So can you work on that? And I can put that right into my goals for the week. We're also going to think about synthetic training. So this kind of looks at, it's kind of more of a top-down approach. So we're thinking more semantics, syntax, pragmatics, maybe auditory comprehension of commonly used phrases that don't provide a lot of context, or identifying words in, common category. A lot of my cochlear implant patients have a really hard time with the numbers. You think about how close 15 and 50 sound. And if you're at a grocery store and they're giving you the total, you want to be able to hear the difference between those two, right? So we might work on that. And then we would move into communication therapy. And this is really thinking, it's talking about talking, where the patient is counseled on conversational breakdowns and repairs, helping them learn how to clarify and helping them learn to shape others' conversational turns. Here's some great resources. I highly recommend getting on and looking at, like I said, MED-EL, Advanced Bionics, and Cochlear America have great resources. Audiobooks are a great way for a person who lives alone to practice listening. Angel Sound is a little dated, but it's a great resource that's online, and I recommend that to almost all of my patients, even my older kids or adolescents who maybe have received a unilateral cochlear implant and are doing single-sided training of that new CI. Angel Sound's a great resource for that. And then this UNC has a great handout. I added that on there as well. So perfect. I was really worried we were going to run out of time. So if anyone has any questions, let me know.
I can read one from the regular chat.
Awesome.
I work in an acute rehab setting, so many of our patients either lose their hearing aids or they left them at home. We have implemented a plan for utilizing assistive listening devices for these patients, especially when doing therapy. I try to focus on providing additional written material for education and carryover strategies learned across all therapy disciplines. Are there any specific recommendations you have for this in terms of type of listening devices that are best? Is there a specific protocol we should focus on for these patients?
Yeah, that's a great question. It's dependent on setting. It sounded like she was in acute. It sounds like you have a lot of great things in place. If anything, I would be educating your team. A lot of these patients have a lot of going on. They might not be used to remembering that assistive device. So educating the PTs, the OTs, the physicians, the nursing staff to make sure they are utilizing that when they're having any interactions with the patient, using written prompts for the patient as well, especially if there's a cognitive aspect that they're having a hard time remembering that. There's not, I would say, necessarily a specific one I would recommend, because it's going to depend, again, type of hearing loss, level of hearing loss, what has brought this patient to this setting, but just being cognizant enough to know that they need that because their hearing aids aren't there, sounds like you're ahead of the ballgame.
Do you have any suggestions for how to begin to search for a job primarily in AR? Absolutely.
So finding out the area you live in, is there a CI team? Is there an ENT that is doing, unfortunately this happens and it kills me. Is there an ENT that's implanting patients and sending them on their way? Reach out, educate them on your role, what you can be doing, get in contact with an audiologist that primarily is doing cochlear implant programming and mapping. Typically, a lot of these audiologists, at least in my experience, have had really specific trainings, maybe a really specific internship during their AUD program that was specific to cochlear implant programming and mapping. Find out who that is in your area and reach out. Tell them that you're interested, you've done some training and some CEUs, and you'd love to take any referrals. I can bet you, I don't think it's probably legal to bet on here, but I could bet you they would be thrilled to hear that someone is interested in this and wants to work as a team for these patients, because a lot of times they just kind of get sent on their way and they kind of flounder. And so if you could reach out and find that in your area, I can bet they would be really interested in working together.
What advice would you have for the SNF setting? I have so many patients who would benefit from hearing aids or even cochlear implants, but this is never a primary focus for them.
Absolutely. Oh, that's such a tough one. I PRN. I went back to work on my PhD, so I PRN at a couple SNFs in town, and I run into this a lot. It breaks my heart. I would say being, again, an advocate, just like you are for other needs, finding out from the family who is in charge of their medical needs, who's making medical decisions, educating on them on how important it would be to make sure that patient has the quality care, the hearing aid, the cochlear implant, so that they can be participants in everyday life. There's tons of research on there that shows once a patient reaches a certain hearing loss, that they are no longer, and they're not getting, using hearing aids or getting benefits from hearing aids because they're not wearing them or they're not appropriately fit. There's a significant cognitive decline because they're not able to participate in the way that they have been in their everyday life. So I would say find out who their family is, educate them on how this would benefit them, and find resources, find an audiologist who wants to work with this population that you can refer them to.
All right. There are a few more questions if you could take a peek in the chat. Our time's up now.
Thank you, guys.
Thanks so much, Katie. All right. Next up, we have Mary Burns, and she's going to talk to us about overcoming clinician discomfort.
I'm going to make sure I'm unmuted this time because the last time I started a presentation, I talked for 5 minutes with no sound going through. So we're already off to a better start.
I can hear you.
And we've got my screen up, so we are good to go. All right. Welcome, everyone. I am super excited to be back for the summit to share with you on this topic that I'm so passionate about. As you've learned so far from the great presentations we've had, that 30 minutes goes by like this. So we are going to really try and dive into the important, the meat and potatoes, I'll call it, aspects of overcoming clinician discomfort and break that down into 5 steps. But please know that this is just getting the topic started. Okay, so you're going to hear me mention several times. I hope that you take this information and you continue your learning journey with it. And I hope that you let the collective be a part of that. Some necessary information to take care of first. Disclosure statements. My name is Mary Burns. I'm a speech pathologist and a board certified patient advocate. Disclosures that are relevant to this presentation. I do receive a speaking payment for this from the Medical SLP Collective, as well as a consulting fee as a mentor for the collective. Everything else you can see up there is not relevant to this presentation. Non-financially, I am a member of ASHA and a SIG 13 member. Providing relevant and up-to-date information is the top priority with the collective. So as such, everything that you're going to see in this presentation was collected from sources cited in November of this year. Anything that is a therapeutic or a treatment suggestion, they are based on my experience and my expertise. So if I'm going to ask you to trust my experience, I should probably start by telling you a little bit about who I am. My name's Mary Burns. I use pronouns she, her. I live in Bend, Oregon, and I have been working as a medical speech pathologist kind of across the spectrum of care for just over 7 years now. I mentioned that I'm also a board certified patient advocate, and I'm really just in this continuous pursuit of expertise in post-acute dysphagia. I don't think that's something I will ever necessarily achieve. Others might have a different opinion on that, but I look forward to trying for it for the rest of my career. But tonight we are going to kind of hone in on another topic that I'm super passionate about, and that is patient rights. So at this point, I have gained a substantial amount of experience working in the healthcare system, but also as a patient and as a family member. So today's talk was inspired by my experiences as a family member, as both of my parents approached the end of their life. Both were at different times, different circumstances, different hospitals, different teams, but there was this common thread that where I was a witness to the way that biases of physicians and of medical teams shaped the choices that were offered to us, offered to my parents, the treatments that were pursued, and ultimately the outcome that both of my parents had in their medical journey. So I want to take that influence and bring it into our lives as speech pathologists and dysphagia clinicians. So before we zoom in on those biases, I really want to highlight an important foundation, okay? Because across professions, this act of putting on our uniform or clocking into work can create this false barrier between the healthcare provider and the recipient, the patient. And that barrier tends to focus on or highlight all of the differences between us, between our two roles, which has this effect of clouding all of the similarities that we share. Because both patients and providers come to that metaphorical table with a lifetime of experiences, of biases, of fears, of goals, of priorities, all of these things that influence their daily decisions. But somehow in this hustle and bustle of healthcare, a lot of times the emphasis is placed upon the influences of the provider instead of the patient. And that's worth taking a look at why it happens and what the outcomes of that are. So I just told you that many times in healthcare, our influences or our opinions as the providers often take the driver's seat. But if we truly want to be providers of person-centered care, we have to find a way to prioritize the well-being, the complete well-being of our patient as a human being that exists beyond the hospital gown, beyond the walls of our facility. And this means well-being that extends beyond that diagnosis of dysphagia, or aspiration pneumonia, or anything like that, and instead infuses your patient's priorities, their experiences, their influences into every aspect of the care we provide. Because patient or person-centered care, I would actually encourage you to use, is this focus on physical comfort, yes, but also emotional well-being. And we have to incorporate their preferences, their values, their cultural traditions, their socioeconomic status. All of these things have to be centered and carried through every element of their care. But a lot of times that doesn't happen. Even though we are well-meaning humans, well-meaning healthcare providers, many times our biases or our influences cloud our decisions and prevent us from reaching that goal of person-centered care, oftentimes without our awareness. And you can see up there that this great quote from Spasonic and colleagues, cognitive biases and personality traits, and they particularly call out aversion to risk or ambiguity. Hello, dysphagia care, right? Cognitive biases and personality traits may lead to diagnostic inaccuracies and medical errors, resulting in mismanagement or inadequate utilization of resources. So that should be kind of scary, right? But it is something that is within our control to address. But first, we have to look at how our cognitive biases or our personality traits influence dysphagia care. Well, it influences the recommendations we give, the education we provide, the treatments we provide, and that's just scratching the surface. And the encouraging thing here, like I mentioned, is that there is something we can do about it. There are so many things that are out of our control in this work, but this thing is within our control. So I promised you 5 steps. And now that I've given you a bit of an overview, I want to talk to you about step 1. This is where we are going to take a mental inventory of our own cognitive biases. And I do want to highlight, I'm going to say it 8 more times just so I drive the point home, that there's simply not time to cover this all. So I hope that this just dangles the carrot enough for you to take this information and continue to expand your learning on the topic. So how many of you have ever heard the term heuristic? I'll be honest, even though this concept was first introduced in the 1950s, I had never heard the term until well after grad school. So heuristics are a normal part of the human experience. I want to make sure you understand that. Heuristics are not inherently bad or good. They're just a thing that we do. And a heuristic is a mental shortcut that allows us to make judgments or to solve problems really quickly. So these shortcuts can be extremely helpful when it comes to basic decision making, simple decisions. But problems can really arise when we start to apply these shortcuts to more complex situations. Doing this can contribute to these cognitive biases, which we're going to discuss now. So technically speaking, there have been, I think, and at this point, somewhere north of 32, I believe it's around 40 types of cognitive biases that have been described and documented. But for our brief time together, I really want to focus on some specific examples that I feel like are particularly salient to dysphagia clinicians, okay, and speech pathologists as a whole, really. So let's talk about confirmation bias. Confirmation bias is the tendency to search for and focus on information that confirms your pre-existing opinion. Okay, so we put our blinders on and we search for and interpret information to confirm what we already thought was right. So as a clinician, confirmation bias can result in us really selectively gathering or ignoring or interpreting information that tells us what we already thought to be true. And we neglect any information that falls outside of that, any information that would disprove our hypothesis. So let's think of an example. Let's say as a dysphagia clinician, you're reading a chart for a new patient and you see they've been taking proton pump inhibitors for several years for a diagnosis of reflux. So you walk into that evaluation thinking, oh, this person is going to have esophageal dysphagia. That's going to be a large element of what I'm working with. So you go in and they tell you they have globus sensation, they have a hoarse voice maybe. Ding, 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 the light bulb goes off. Oh, yeah, duh, they have reflux, they have esophageal dysphagia. But you make that confirmation in the absence of any other workup, no imaging, no other tools to evaluate. You let those 2 small pieces of information confirm the idea that you thought was true before you walked in the door. That's an example of how confirmation bias could negatively impact our dysphagia care. Anchoring effects or anchoring bias really go kind of hand in hand with confirmation. So this is where a mental shortcut can lead us to a bias where we prioritize information that supports our very first impression of the evidence, even if that is incorrect. So those kind of lay over each other or go hand in hand. Availability bias is another one I really want to discuss. So availability bias describes this tendency we as humans have to weigh the likelihood of something according to how easily we can recall it. So at times, this can be helpful, right? We've all heard that phrase. If you hear hoofbeats, think horses, not zebras. right? Many times the thing that comes most easily to mind does apply. We don't live in an episode of House, but not always, right? Defaulting to only believe the thing that comes most easily to mind can lead to significant errors in healthcare. So we have to be cognizant of our tendency to take this mental shortcut, and when that can devolve into a bias that we are applying to our care. So let's say the last 5 patients I've seen who had COPD and dysphagia all presented very similarly in their clinical exam. Their diagnostic exams were very similar. I made the same recommendations, almost, give or take a few tiny tweaks, right? I might be able to develop a hypothesis about that 6th person with COPD and dysphagia who I go to see, but I cannot, just because that information from my last 5 cases comes to mind easily, I cannot take that information and automatically apply it to this distinct individual who is now sitting in front of me, because that would be compromising the care that we provide and potentially the health of the patient sitting in front of us. Representativeness, that's a mouthful, bias. There are some different types of this bias, but that have been explored. But really simply put, this bias can lead us to make judgments or decisions based on how well something fits into a pre-existing prototype that we have in our mind. So for example, we might make treatment decisions based on how well a patient and their symptoms match this mental image that we have of a certain diagnosis. And this can really lead to us overemphasizing certain information and potentially ignoring others in making medical diagnoses and making treatment plans. But this bias also encompasses the way that we can apply inaccurate stereotypes across populations. For example, oh, well, this person lives in the country and lives on a farm, so they must be interested in these things. So when I provide their care, this is what we're going to target. Or this person is from this culture, so they must eat this thing. So this is a thing that we need to focus on in their dysphagia care. That's an example of representativeness bias running away with you. So remember, that's just a quick and dirty intro to a few of the potential biases that can arise from our mental shortcuts. So step 2 takes us to, all right, we've recognized them, which I hope that you will continue to work on because it's not a 5-minute talk, okay? And as you explore that, remember, when you identify them, that does not make you a bad person, a bad clinician. It makes you somebody who is seeking growth, because we are all subject to these biases. The problem comes when we don't recognize and try to address them. So that was step 1, build your inventory. Step 2 is to start to deal with what we learned. This is where we're going to seek opposite proof and start to address or combat our own cognitive biases. Because it's not just enough to be aware of them. If we want to reduce their influence, we have to take action against them. So let's look at what we could do to address availability bias. Remember, that's when the thing that comes to mind most easily must apply, right? One of the best ways you can address availability bias in the care that you provide is to intentionally seek out diverse experiences, collaborate with your colleagues, both in and out of your discipline, share your insights on cases with others and get feedback, ask questions, right? The collective is a great place to combat your availability bias, because it doesn't matter if you've posted the question or you're reading somebody else's, there is a never-ending supply of experiences and expertise that all bring something different to the situation and help you look at a situation differently than what maybe was the first thing that came to your mind. Affect bias, which I didn't talk about on the last slide just for time's sake, but affect bias is the way in which our decisions can be influenced by our temporary emotional state. So it's important for you to build awareness and check in with your emotions when you're making decisions. And if needed, delay the decision making until your emotions can regulate. One of the examples I always think of for this is, what is your decision-making process like when you decide in terms of how many days a week you want to see a patient who maybe says some mean things to you, doesn't love therapy, doesn't really want you to be there, kind of grouchy, versus the sweet little old lady who always wants to talk to you and ask you about your life and is just delightful, right? How does your emotional state influence the decisions that you make for those different patients? Because both deserve your care. Same thing applies when we make decisions about discharging patients from therapy. We have to check in with that and be aware of our own emotions and the fact that they influence your decisions. Ways to fight confirmation bias: actively seek out the opposite of what you believe to be true. Think about the high school debate team, right? They're presented with a topic, your team A, your team B, and they tell you you're for it, you're against it. Doesn't matter what you think, you have to craft your argument. So when you find yourself feeling certain or almost certain that you know what's going on, challenge yourself by actively seeking out something to disprove it or something to prove another hypothesis. In terms of representativeness bias, you have to build awareness of your tendency to make judgments based upon this stereotype or this prototype in your mind, because these run the gamut of everything from things that seem small, like, oh, well, that little lady is, she weighs 100 pounds and she's got that curly white hair and she's wearing a knit sweater and, all of these cute, oh, she's a typical cute old lady, right? She must be sweet and lovely and she'll do everything I say, right? That's a pretty small stereotype to have in your mind, maybe not as harmful. But think about the stereotypes that you might be applying when you're asked to work with someone who has a substance abuse disorder, all the way up to those stereotypes that continue to hold up systemic racism in the healthcare system. We have to be addressing these at every single level because they all matter. And so point it out to yourself, ask others to point it out to you when they think you're using these stereotypes, and ask permission to do the same for others, because we all have to hold each other accountable in fighting this. So I know that's a lot of information in the first 20 minutes, but we got to get on to step 3. Right? Another key element in letting go of our own discomfort and fears as dysphagia clinicians and ensuring we center our patient is to obtain and prioritize their perspective on the situation. So if you are not already using a patient-reported outcome measure in your dysphagia care each and every time, please start doing it. This is a beautiful and easy way to expand that narrow lens that we have as clinicians and start to challenge our own mental shortcuts or our own biases and take this larger view of this person sitting in front of us as a whole entire human, not as just our patient. So if you need examples of this, feel free to reach out in the chat or after, but some quick, easy examples: 8-10, the visual analog scale, all the way to more comprehensive tools like the SWAL-QUAL or the Dysphagia Handicap Index. There's a lot of great tools out there. Step number 4 is to remember the rule. I don't know about you, but I love an acronym. Okay? And one of my favorites to help me remember and check my own mental shortcuts, my own biases, and ensure that I am centering the patient in front of me as a human being is to remember the rule. So I've borrowed this from the motivational interviewing space, but it absolutely applies here. So the R stands for resist the writing reflex. And what that means is when you feel that urge that comes from deep inside your guts to fix it When a patient is making a decision that you don't believe is in their best interest, stop it. Okay. Our job is not necessarily to fix it. So anytime you feel that, and we all have, right? I continue to feel it. But when you feel that draw to say, oh, no, you shouldn't do that. And here's why. Stop yourself. Pause and check in with why you are feeling that urge. The U stands for understand your patient's motivation. So this is where we get curious about why that patient is making the decision that they're making. And we do so without judgment, which is the hardest part, right? Get curious and be open-minded and just talk to them to start to understand why they are making those choices. The L stands for listen, 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 and listen some more. We should always be listening more than we're talking in therapy, which I find is something that is particularly hard for speech pathologists, myself included. But if you find that your patient isn't giving you something to listen to, stop and really spend some time thinking about, have I created an environment that is safe and accessible and accepting for them to be heard? I do recognize that, working with individuals with communication or cognitive barriers, that verbal communication can sometimes be limited, but that's where that accessibility part comes in. It may not be them telling you something verbally, but what are they telling you non-verbally through their behavior, through their actions, through their gestures, right? How can we make it more accessible for them to communicate with us? And E stands for empower your patient. One of the most effective, albeit not easy, ways to minimize the impact that your cognitive biases can have on the care you provide is to take the power out of your hands. Put the power into the hands of the patient, of their medical power of attorney, their family. Foster self-efficacy and use informed decision-making, promote informed decision-making, because then we are taking ourselves out of that process where we can really influence things based on our own lens. And as cliche as it sounds, your fifth step is to keep practicing every day, every patient. Know that you are going to make mistakes. That doesn't make you a failure. It doesn't make you a bad human, a bad clinician, right? Sometimes you might even not catch those missteps until years later. Sometimes I'll run into a situation and I think back, I have a flashback to my CFY and cringe at something I did, right? But if we are all going to continue along this journey of becoming the best dysphagia clinicians that we can be, we have to be able to recognize our mistakes, recognize our own cognitive biases, figure out where that breakdown happened, apologize when we need to, explore how you can correct it, and try again. Because if we give up every time we make a mistake, these people who do need us as a part of their care aren't going to be able to get the access to the services that they need. So those are your 5 steps to help start the process of moving beyond your own discomfort and focusing more on your patient and centering them. Got a couple minutes left for questions. And I do have, if you're interested in learning more about what we've talked about tonight, these are the resources I would recommend and the resources that were used for this presentation.
Thank you so much, Mary.
Yeah.
All right, let me see. I think a question just popped through. Okay. Giving the patient-reported outcome can be done outside of therapy. We get 15-minute credit for dysphagia therapy and acute care. So looking at not doing this in therapy time.
I think with the right patient, you could absolutely do it outside of therapy. if you, and also there are some of those quick tools like the visual analog scale might be a better one for people who have very limited time, because it's just, you draw a line, you explain it, you have a mark on the line, right? So that takes less than a minute. With some of those longer tools though, yeah, with your patients who are engaged and cognitively and communication wise able to complete it, you could absolutely leave it with them.
Okay. Another one is, how do you become a board certified patient advocate?
That process was studying for a board certification exam. And then you, very similarly to ASHA, so you have to pass your boards to get the certification. And then similar to ASHA, you have to do 30 hours of continuing education credit on certain topics within a 3-year certification period.
All right. Let me check. All right, that was our last question. Thank you so much, Mary. You're getting lots of great responses. That this presentation was very insightful, very helpful.
Thank you so much for having me.
Thanks for coming. All right, so we are going to round out our last night with Vanessa Neal, and she's going to talk to us about support and training for care partners of people with dementia.
Okay, can you see my screen?
I can.
All right, great. Well, thanks for having me, and congrats on making it this far, everyone. It's 9:30 for me. I know that might not be the case for most people, so congrats if it's that late for you. Disclosure statements. I received payment from the Medical SLP Collective for this presentation, and I have no non-financials. The information is from sources cited within the last 5 years. Ideas in treatment are from research presented here and my clinical expertise. A little about me. I live in Tampa, Florida, beautiful Tampa, Florida. This is my husband, Elliot. He's a neurosurgery resident, and we just got a puppy a couple months ago. So his name's Archer, and if you are interested, you can follow him on Instagram. He has quite a lively page that I'm a little bit ashamed, but obviously not that ashamed, that I created for him. I am a researcher and speech pathologist. I got my PhD at University of South Florida in 2019, and I specialize in memory and communication interventions for people with dementia. So what is the role of SLPs in serving care partners? Well, it's 3 parts in total. And let me just move this so I can see my notes. So first and foremost, education, about cognitive and communication changes and the strengths and deficits that come along with dementia, and especially as the disease progresses and how that changes. Secondly, support, recognizing the other psychosocial and emotional needs the caregivers have, and making recommendations for services and community resources. And finally, training, specific strategies and techniques for supporting and maintaining satisfying conversations, and for modifying related problem behaviors. And this goes from diagnosis to end of life. So I'm going to start with talking about family and unpaid care partners. So in total, 11.2 million in the United States in 2020. They are mostly women. A third of them are over the age of 65. Largely white. The next largest percentage is African American, then Hispanic and Asian. And in total, it's estimated that unpaid care workers provided the hourly equivalent of $257 billion worth of care in 2020. And just a little fun fact, it's 50% of the net value of Walmart's total revenue for the year of 2020. So kind of approaching that, which is interesting. And 60% report high stress and 40% report depression. And so with that, kind of understanding stress and burden and how this informs our intervention approaches. So because this is copyright, I can't show the image, but you can look at the sources below to find it. And I'll try to do my best to explain it here. So the way researchers understand burden is that it's an outcome of a pathway. And this pathway is how the caregiver internally appraises their stressful situation. So they are asking themselves, is this an external stress of caregiving pose a threat to me? And do I have the coping strategies to prevent myself from harm? If there is a threat and I don't have the coping strategies, that can lead to burden. And burden is what increases someone's risk for poor mental and physical health outcomes. So when we are designing interventions for caregivers or care partners, I'm trying to use that language more now, we are targeting their cognitive appraisals and trying to supply coping strategies to combat that burden. And just a quick note, the reason I'm trying to use the language of care partners is because it equalizes and sort of creates a balance of power between not only the person being cared for, but also the clinician. So we like to think of the training relationship as equal responsibility. So I'm just as responsible for the success as you are, and it's not sort of a authoritative relationship. All right, so back to this slide. These are the things that family care partners need to know. There's of course 1,000 things they need to know, but for SLPs, these are some areas to prioritize. How dementia impacts communication, how communication and impaired communication impacts behavior, strategies for supporting communication, how to reduce demands on impaired systems and strengthen relatively spared systems, and resources for coping and stress reduction. And so these are just some educational resources. There's obviously plenty out there. I really like these Dementia Australia help sheets. They come in many languages and in every topic and disorder area you can imagine. There's also the American associations that we have here. Training videos, the UCLA health training videos are some of my favorites, and they come in both Spanish and English. And for those care partners who may be looking for services like respite or support groups, this aging services locator can be a handy tool. In terms of another resource for strategy training, it's beneficial for care partners to know external memory aids, what they are, how to use them, how to design them, how to structure the environment to support communication and memory, and just general communication strategies. And a resource that I found helpful is this one here, and you can get it, I think it's about $30, $35 on Amazon. Highly recommend it. It has several templates you can download and use for education and also for creating your own memory aids. I use it quite a lot in my own practice. Here is an example of a tip sheet. If anybody has used memory books, you know that they have a plethora of research around them. They are known to improve the quantity of utterances, factual communication, balance out conversation between a person with dementia and a conversation partner. And also they can be used to address challenging behaviors. So this is just an example of a tip sheet that you can find for free online on brushdevelopment.com. Jennifer Brush is a speech pathologist who developed her own private practice dementia consulting business, and she has a lot of great resources on that website. And for those that are not familiar with memory books, this is what a memory book is, or at least an example of some pages. It's one I created for a couple who lives in Tampa, and the husband had dementia, and they needed a tool to have a conversation about where they were in life now, and that they lived far away from their family members, their son specifically, and the wife needed a way to orient her husband to that. So that was part of the reason for this tool. Memory books can be extensive. They can be a lot of work to put together. So my tip is to make it easy for care partners. Make a template if you can. If not, there's pre-made ones online. And I just have some suggested topic areas here for you. These are just some sample pages of what my template looks like. So in the past, for my semi-tech savvy care partners, I have sent a Google document to them that is a template, a PowerPoint template, and just allowed them to fill it in. This just happened to be a client I was seeing over telehealth, so we were able to review it together. online, which was nice. Another helpful memory aid is reminder cards. And reminder cards are particularly helpful for repeated statements or questions. And these are just a set of instructions that you can find in that book I recommended in the previous slide. And you can, instruct caregivers how to create the cards using I statements, declarative statements, simple sentences on a note card, and instructions for how to present it. So stating the answer to the question or concern, writing the answer on an index card, reading the card aloud with the person, and then giving it to him or her. And then when the question is repeated, instead of saying the answer, directing the person to the card. So you would say, read the card, or I think the answer to that question is on your card. And each time the question is repeated, you repeat those steps. And the rationale behind that is it over time trains the person to refer to the card for their question as opposed to the care partner. And so that can reduce burden and just give the care partner one less thing to do. And the research shows that as well. Another helpful tool for your toolbox is to empower care partners to collect baseline data. So this can be helpful not only for your own purposes, but also keeping care partners accountable. And it can help them to understand, how things are going and help you both troubleshoot if there are any potential issues. So for this, you're going to ask the care partner to identify or describe the challenging behavior, determine which is the most stressful, and then write them. This data sheet from Bourgeois and Hakeem-Bourgeois chooses 2, which I think is a good starting point. Discuss a time for recording the behavior, ideally the same time every day, so maybe before bed or at lunchtime. Practice recording the behavior with role play. And 1 week later, review the sheet, or your next session, review the sheet and discuss which one's the most problematic and which one to target first and move on from there. Some basic communication strategies. This comes from a study by Ripich, and it has been replicated since. These are communication strategies that were actually taught in the professional care setting, but are just helpful in terms of an outline. Mary was saying she loves acronyms, and I completely agree. And I think this is just a helpful tool and kind of covers all the bases when we talk about supported communication strategies. So the focused approach: face the person, calling by name, eye contact, orienting to the topic of conversation. So saying, I'm here today to talk about your family, or I'm here to talk about X, right? Continuity, trying to maintain the topic. If they go off track, you can say, okay, Mr. Smith, but today I want to talk about this, or that's nice, but today we're going to talk about this. And if you're changing, be clear about it, make clear transitions. Unsticking for overcoming communication blocks. If the person is confused, maybe clarifying for them and then repeating the sentence using the correct word. Being mindful of the structure of questions. So rather than an open-ended, what do you want for lunch today? You can say, would you like a sandwich or a salad? So providing choices that are in line with the person's preferences. Exchange ideas, needs, and feelings. Keep up the normal exchange of ideas, begin conversation with pleasant topics, ask questions that persons can answer and give clues to answer. So, not quizzing or asking any difficult questions. Direct types of verbal messages, simple, short sentences in active voice, specific concrete nouns, communicating in as many modalities as possible. So the only thing this is really lacking is that instruction and visual cues. And I've actually included some extra slides at the end of this presentation about additional strategies that might help with that. And so that you can review on your own time. And just a general tip, there are so many things that we can recommend for family members. And so I find it helpful to have a binder or a book like that book I recommended earlier of just examples to show families. And not only does it add credibility to what you're saying, like these things actually exist, but it adds context, which helps them understand, which helps with buy-in. So it's just something I highly recommend. And you can just pull things offline. You can use them from your own practice, but having a concrete example is really helpful for families. Support. So this goes under the support category of the services we provide. These are obviously some resources for online support groups, but there's definitely plenty that are provided in the community, and those can be found online as well. Potential benefits of support groups: decreased burden, depression, increased subjective well-being, satisfaction with care, ability and knowledge, and decrease in care recipient symptoms. Counseling. So this is something that falls under the practice of speech language pathologists, and I've just put a couple resources to the right for you to reference at another time. Coaching. So Audrey Holland and Ryan Nelson, they advocate for an approach that is coaching grounded in wellness and emphasizes normalcy and health. It focuses on problem solving, developing action plans, and sort of differentiating with what's within the person's control and those that are beyond the person's control. And I'm going to go into depth about problem solving and action plans specifically. So this is a problem solving strategy that was developed by Michelle Bourgeois. And these are just the 6 simple, pretty straightforward steps, but I find it very easy to reference and just something that's simple to replicate in your own practice. So the caregiver would be asked to achieve a calm state of mind, define the problem and be as specific as possible, list as many solutions as you can think of, consider pros and cons, and pick the solution that has the best chance of working, plan and carry out that solution, evaluate the results, and repeat steps as needed. So this can seem kind of simple and kind of like, why do we have to tell this to caregivers or show this to caregivers? But I think when you're in a state of being so overwhelmed and having so many decisions ahead of you, having a guideline like this can be a very helpful reference. And the second strategy I want to talk about in line with counseling is increasing pleasant activities. So this is also developed by Michelle Bourgeois and came from an NIA grant for caregiver training that she conducted. So this pleasant activities process, so this is just basically a self-care strategy for care partners. The first step is to decide what activities are pleasant, decide how often and when you'd like to engage in those, what obstacles may prevent you from doing those things, how can you overcome them using problem solving, and start the pleasant activity and congratulate yourself. So again, just simple steps that can remind a care partner to engage in things that make them happy. This is not in line with that study, but is a resource that was provided to me during my work with the VA. It's a pleasant activities log, and it could be something, again, to help a care partner set a goal or to keep track of something, maybe have something concrete for them to look at and be proud of. So just another resource for you all. Another helpful resource is this caregiver activity booklet or self-care activity booklet. And there are various activities within it on mindfulness, breath work, encouraging exercise, crafts, and encouraging reaching out for support. So just another tool to provide to care partners who you think may need that support. And these are general tips with working with care partners, specifically family care partners. The best outcomes in psychological distress and care partner knowledge were found when recipients were involved in the intervention. So as opposed to me telling a spouse what to do, really involving the care recipient and having a didactic applied training approach. Programs that were tailored to the care partner's needs. So not just sort of a generic approach, but something that's specifically tailored to what that person needs. Programs that addressed multiple needs. So of course, we are not superheroes. We can't do everything, but this can be a reminder that providing resources can be helpful, and providing referrals to maybe things that aren't within our practice can be helpful. Programs that lasted over the duration of caregiving. So this goes back to what I said about from early stages to end of life, SLPs have a role. And throughout time, the dose, the intensity, and the focus was adjusted based on risk and need profile. So really, again, tailoring to what the care partner needs. So now I want to shift to professional care partners, and specifically CNAs. CNAs provide 90% of direct care in the nursing home. Key facts about them: they're overworked, underpaid, stressed. They have they shoulder much of the responsibility without power or authority. They may feel pressure to meet unreasonable work expectations, and they feel the need to cut corners because of that. The resident outcomes are better if CNAs are empowered. They value growth opportunities, and resident-centered environments promote CNA well-being. So potential barriers to training CNAs, if that wasn't clear already, that they may have lack of buy-in and carryover of the strategies we recommend. In addition, even if a CNA is cooperative and wants to do the things we're recommending, the institutional culture and climate may be preventative, and the person may have a workload, or they may be saying, why are you doing activities with a resident? You should just be feeding them and taking them to the bathroom. So it could be a variety of barriers that we could experience. And so with that, understanding adult learning principles is important, because behavioral interventions require behavior change. And what adult learning principles do is they help us have a base of support for structuring our interventions and the components they should include. So let me talk a little bit more about that. So the first principle of adult learning is the need to know. So adult learners need to know why they need to know the information they're being taught. They need to know, they need to be responsible for their own decisions. They need to have their experiences acknowledged and respected. They need to be ready to learn. They need to be in a place where they're ready to learn. They need to have learning that's oriented to their current situation, so relevant to them, and then also motivated. So what does this mean for CNA? So kind of narrowing in here, and Page and colleagues in 2019 did an excellent tutorial on how specifically this applies, adult learning theory applies to interventions for CNAs. So the first component, respecting the CNA's insight. So acknowledging how many years they've been at the facility. If they had a family member who had a similar condition, or just really getting to know them and showing value for their time and effort. Accountability, so consistently requesting feedback from CNAs regarding the use of strategies, and also educating, so explaining the treatment and how its effectiveness will impact the resident's quality of life and the CNA's workload. So explicitly stating the value, going back to why do I need to know this, that adult learning principle. Demonstrating, perform the strategy during daily care and in a variety of settings. Problem solve, provide feedback. So discuss problems, check in with them. How's it going? And problem solve a solution. Reward and recognize, so reinforce by saying thank you. Maybe you give something like a physical certificate, or you share their progress with the administrative staff. How does this look in practice? So respect could look like consulting the CNA. When does Mr. Baker fall? I'm talking about a resident's falls. Accountability, checking in about performance. So the activity recommended for this resident was folding newsletters. How is he doing folding the newsletters? Educating, so we're providing a rationale of why Mr. Baker was recommended to fold the newsletters, and why the intent was engagement and reducing the number of falls. Demonstrating, conducting therapy in a physical location. Problem solving. Say there's a problem, you could suggest maybe Mr. Baker's too distracted in the living area, and you can set up a task in his room. So problem solving, providing feedback, helping with that process. Reward and recognizing the CNA by thanking the CNA for setting up the task for the resident. So Page and colleagues also did a study on a communication support plan, which kind of helps bring this into context a bit more. So what this was SLPs and CNAs collaborated to create communication plans for residents. This was a small study with 10 CNAs, 5 with an intervention group, 5 in a control group. CNAs chose 2 residents they wanted to make plans for. And the SLP worked with the CNA to make the communication plan, and I'll show you one of those in the next slide. But only the intervention group got 5 to 6 follow-up sessions within a 2-week period. The control group, that group that didn't get the intervention, didn't get the SLP session. So they had a 2-week period to just have the communication plan and didn't get any sort of follow-up with an SLP. And then they did an in-depth interview 2 weeks after usage. So this was a qualitative study. So this is just an example of a communication plan. You can see that it talks about how the resident communicates, how to communicate with the resident, what behaviors mean, what habits this resident has, and just general facts about the resident. So just kind of a little cheat sheet of how to communicate with this person, but also their likes, interests, life history, etc. So what they found was the CNAs perceived the communication plans as useful to facilitate communication with the resident. Having the communication plans transformed their negative views of the resident into positive ones. They had enriched relationships with the residents, having more familiarity with the resident and how they communicated made work less effortful. And what they found, particularly the difference, they didn't find major differences between the two groups, but one group had what they perceived as greater incentive to use the plans. And they said that during the interviews, the CNAs that did not have SLP support didn't mention referring to their communication card or the communication plan as much as the other ones did. So they perceived that as perhaps having a lesser incentive to use the tool. But in general, they found them helpful, so that's good. So in general, when we're designing programs for CNAs, multiple modalities, print, video, live demonstration are great to have. Tailored trainings, again, increasing that motivation, right? Person-centered training for our care partners. Training should be short in duration, in the moment bursts, as opposed to a long didactic session. So, you know, maybe you're doing a role play intervention, or, you know, you're doing it in the moment in care, say during a shower, during mealtime. Or maybe it's a quick tip during shift change, something like that. Collaborative. So again, going along with helping the CNA with having them prioritize what their biggest challenge is, and helping them develop the intervention with you. Recognizing the contributions and values of the trainees, again, showing appreciation and respect for their experience and their expertise. We're not coming in as the know-all being. It's a collaborative approach. Assess outcomes of the training and revise as necessary. So again, feedback and checking in, and problem solving. An excellent resource that you can find for free is provided by a colleague of mine, Natalie Douglas, also a previous mentor of mine. And you can find it for free on her website. And it essentially outlines for you a program she developed for training CNAs. And it starts with just basic facts about how to support communication and memory of people with dementia. And then there's sort of a question and answer workbook where she allows the CNA to kind of express the challenges they're having and the plan to address that. So really cool. And she's actually working on a grant right now, a clinician researcher grant, to pursue that further and implement that in some nursing homes. So it's exciting stuff. I always get questions about goals, how to write goals for things. So I thought I would include that. And that comes from this book that is actually, I'm not getting anything off of this, but I just wanted to, as a courtesy, tell everyone that you can get it right now for 25% off if you use this code before December 31st. I won't read the goals. I'll let you refer to those on your own, so we have some time for questions. And last, but certainly not least, here are some resources for serving diverse populations. And there are also a list of many more resources in that book that I showed you previously. And here are my references. And thank you all so much for listening.
Thank you so much. I do have a question that just came through.
Sure.
Would you approach creating a memory book differently for people also with primary progressive aphasia? If so, what changes would you make?
Yeah, I think it's all going to be based on the client's needs, right? So if their needs are more communication based, then perhaps you have a communication book as opposed to a memory book. So maybe you have targeted life situations. So you have something that's for using at a restaurant or in conversations with grandchildren or friends, right? So more specific to communication needs. And it could look very similar to a memory book, but maybe it has, pictures and multiple words, and it's organized with tabs, something similar to just a communication book as opposed to memory.
I think we have time for one more. Do you have any advice or research or suggestions that support the utilization of visuals with individuals with dementia? My facility's memory care unit was recently told by corporate that it looked like a kindergarten, and they felt that it was reduced dignity of the patient. And if the resident needs help, the CNA should be there to help them.
Okay. Yes. And the answer is there's many resources out there. I'm trying to flip to that book. This book has a lot of excellent resources in terms of citing the research. Michelle Bourgeois, who is the author of this book, is essentially our pioneer for using visuals with people with dementia and using memory books. And the dignity issue it all makes me so mad. And because the thing is, it's less dignifying to allow someone with dementia to roam around aimlessly in a facility and not know where they're going, as opposed to having the cognitive supports that they need to function in that environment. And so what it comes down to is supporting their remaining abilities. So what we know is that people with dementia have preserved ability relatively late in the disease to read and recognize images. And there's a way to make those look respectable. So maybe it's something that just needs some reformatting. I would also recommend going to Jennifer Brush's website, brushdevelopment.com, which is right here on the bottom here. She has excellent examples for creating wayfinding cues, which are just signs that are directional, and how to make those look nice and pretty, because I know that that's a concern for a lot of facilities. So.
All right. Thank you so much for this presentation.
Yeah, thank you, everyone.
All right, everyone, this concludes our third night of the MedSLP Summit. Thanks so much for joining.